This is a presentation with several cases. As we know, malposition of an intraocular lens, either it is anterior chamber or pupillar or even posterior chamber IOL, is one of the major causes of corneal decompensation needing corneal transplant. Together with the keratoplasty, either penetrating or endothelial, it is advisable to remove the guilty IOL and to replace it with a correct position posterior IOL, far from the cornea and from the graft. And you can do this either in concrete procedure or sequential surgeries. We selected 14 patients with bullous keratopathy determined by different types of IOLs, Fyodorov pupillary IOL, anterior chamber IOL, and the third group is with dislocated posterior chamber IOL, to whom we perform concurrent procedures, ultra-thin DSAEK with IOL removal and the new IOL implantation according to the local anatomy. In our series, all of them had combined procedure. Regarding the IOL, there were three situations. First group, anterior chamber or pupillary IOL have been removed and we put a posterior PC IOL on capsular remnants. The second group, either AC IOL or pupillary IOL were removed, but we had no capsular support at all. We removed them and we need to put another one fixed on sclera, sutured. And the third group is a posterior chamber IOL dislocated with a capsular bag, and we needed to reposition this pre-existing PC IOL. So we kept the bag and the IOL in reposition. Here are some examples. All of them have PC IOL on capsular remnants, so not sutured. In this case, we have a Fyodorov lens and pre-op. The superior line shows the pre-op images and the bottom line, the post-op images. Again, some cases when we needed to suture a sclera, the PC IOL, because there was no capsular support. Here we have Fyodorov lenses, and this is a post-op images. In some cases we needed also pupilloplasty, you will see the video. And here we had also IOL sutured at sclera, but this time we had anterior chamber IOLs. This is a case who required afterwards a second transplant, which was a PK. And the third group, these are three cases of old patients over 80 years old with dislocated IOL, posterior chamber IOL. You can see here the limit of the bag and the IOL and how they looked post-operatively in these combined procedures. So this is the first one of the cases. I will go quite briefly through them. This is a Fyodorov lens which needed to be explanted. In these cases, as you will see again, ultra-thin DSAEK part of the surgery is more or less standard. But one of the most difficult parts of the surgery is to deal with the IOL, the guilty IOL, which needed to be explanted. And Fyodorov, maybe the younger doctors don't know, they have three haptics anterior to the iris and three round haptics, closed haptics posterior to the iris. So we need to cut the anterior ones and then to cut the posterior ones, extract the optic part, and then go and chasing the round haptics remain behind the iris. Of course, anterior vitrectomy, and again my favorite technique at that time, that was 4 or 5 years ago, we didn't have Gore-Tex, so we used acrylic suture with Prolen in ab interno technique. Here you can see the DSAEK, again, lamella prepared in the OR using Busin Glide, and the final image quite nice. And this is a similar case. I just wanted to show you that in this case there were plenty of remaining cortex, and we ask ourselves, should we need to remove them or just leave it there? But if you leave it there, you can have a tilt IOL afterwards, so it's preferable to clean everything. Together with the vitreous, of course, but in this case, in some cases, when you remove the pupillary IOL and the cortex remnants, you can have ruptures of the structure of the sphincter, so you need to perform pupilloplasty, like in this case. And this is the third one. I will go even further. Again, you have a Fyodorov IOL, again the same difficulty in explanting it. You have to be careful not to leave it, you don't want to have them on the retina, but because we carefully examined the periphery and we saw that there are significant and sufficient capsular remnants, we implanted the 3 pieces Alcon IOL on the capsular remnants, and this is what we did. The same thing here, only that here we have an anterior chamber IOL, which is much easier to be explanted if it's not buried in the iris or whatever more complicated eyes, like traumatized eyes can be. And again, we have sufficient peripheral capsular remnants, but be careful you need to have sufficient capsular remnants, otherwise you can have a dislocated IOL and you can find it on the retina or something. This eyes went quite well. This is the post-op image. And this is the third group of the case that I mentioned, all patients with pseudoexfoliative syndrome and posterior chamber IOL dislocated together with a bag. We used the anterior approach. We prepared scleral grooves because our intention is to keep this IOL, and we always keep the IOL when we have favorable IOLs. I mean IOLs which have holes on the haptics. It's a pity not to use them, and it's a less traumatic procedure instead of taking it out and exchanging with another IOL. We are using hooks to fixate the bag on the CCC. First, as you saw, we externalized the superior haptic and then the opposite haptic, and we sutured it with a ProLens suture. Then we passed to the second part of the surgery, DSAEK, and again this is more or less the same standard technique for DSAEK. All surgeries were uneventful. All eyes had well-positioned PCIOL after the combined procedure. All cases had significant improvement in visual acuity, which was present throughout the follow-up time for 5 years, and had no significant complication except for some cases. One eye needed early rebubble, but it went okay afterwards. One case developed early host cornea trophic ulceration, which was solved only with penetrating keratoplasty, and she did well afterwards. And one case developed secondary glaucoma who needed filtering surgery, but the same case had late endothelial failure at 4 years, and he just had recent DSAEK. These complex eyes need personalized approach according to the local situation, and the decision for which type of keratoplasty and which type of IOL are the most appropriate for each patient belongs to the surgeon and his experience. When the decision is for endothelial transplant, the challenges are mostly related to the management of the IOL, the port visualization, IOL removal itself, completed cleaning of the anterior chamber, incision placements, and so on. All of them can be challenging, but the UTDSAEK part of the surgery is more or less standard, apart from the communication between the anterior and the posterior cavity, which can lead to air bubble escape. Thank you very much.